Good evening, everyone. This is a case of a 50-year-old gentleman with drowsiness. So, this is a case of 50-year-old gentleman who was diabetic for 10 years, which was poorly controlled. He has a history of diabetic retinopathy. He had mild chronic kidney disease with baseline creatinine of 2 milligram per deciliter. He presented with fever, abdominal pain, and dysuria. He was treated in a local hospital with injection piperacillin tazobactam, and he was referred because of worsening edema, renal dysfunction, and altered sensorium. On examination, he was stuporous, he had gross edema, his blood pressure was 90 over 60 millimeters of mercury, he had elevated GVP, and he had a right renal angle tenderness. On evaluation, he had neutrophil predominant leukocytosis. His RFT was deranged with creatinine rising to 5.4 and to 7.5 over the next 4 days. His CRP was 400, and routine urine examination showed plenty of pulses. A urine culture was sent, and CT abdomen was taken. The axial film, the axial CT showed a grossly enlarged right kidney with a gas formation and with a pararenal extension suggestive of right emphysematous pyelonephritis. He was initiated on injection meropenem and he was given 1 dose of injection vancomycin. Intensive diuresis was begun for edema with good response, and there was weight loss of more than 12 kg over 1 week. Blood and urine cultures grew ESBL Klebsiella with intermediate sensitivity to piperacillin tazobactam and cefosalbactam, but sensitive to carbapenems. The antibiotic was stepped down to ertapenem, and he received treatment for another 2 weeks. Renal function improved marginally, but urine output was good, and clinically he improved. He was put on follow-up. Edema has come down over 2 weeks of follow-up, and creatinine has declined to 5.5 milligram. So, this is a case of emphysematous pyelonephritis. Emphysematous pyelonephritis is a severe necrotizing infection that affects the upper urinary tract, involving the renal parenchyma and sometimes the perirenal tissues of the kidney. Usually leads to gas formation in the renal parenchyma, collecting system, or perinephric tissue. Escherichia coli and Klebsiella pneumonia are the most common pathogens associated. Other organisms are Proteus, Enterococcus, Clostridium, Aspergillus, and rarely Candida species. The most prevalent risk factor is diabetes mellitus. Others are obstructive uropathy and hypertension. Mostly older patients and females are affected with a female to male ratio of 4:1. Mortality used to be 40 to 90% previously, but with advanced medical management, now it has come down to 20%. The pathophysiology is mainly uncontrolled diabetes leading to uncontrolled bacterial propagation and disease progression, and there is gas accumulation observed as a consequence of microbial fermentation of glucose and lactate. The most common gases that accumulates is carbon dioxide, then hydrogen and nitrogen. Then urinary tract obstruction can reduce renal blood flow, tissue perfusion, exacerbating the infection. CT imaging is the most effective diagnostic tool to detect emphysematous pyelonephritis with 100% sensitivity compared to ultrasonogram having a sensitivity to ranging from 41 to 69%. So this is the Huang and Xen EPN classification. There are 4 classes. In the class 1, there is gas accumulation in the collecting system alone. In class 2, in the parenchymal region, renal parenchymal region. In class 3, which is divided into 3A and 3B. 3A, there is extension of gas into the perinephric space. 3B, there is extension of gas into the pararenal space. And class 4, there is emphysematous pyelonephritis in the solitary kidney or bilateral kidneys. So this forms a basis for a management of emphysematous pyelonephritis. So in class 1 and 2, mostly they respond to antibiotics and percutaneous procedures. More aggressive management is advised in class 3 and 4 according to this classification. So mostly patients respond to 3rd or 4th generation cephalosporins or carbapenems. Alternative option for combination therapy involves amikacin and 3rd generation cephalosporin. The standard duration of treatment is 14 to 21 days. Percutaneous drainage is recommended for patients when there is extra renal collections. and DJ stenting is required when there is obstruction. So urine culture alone may not help, and culture from the drainage should be obtained to guide the antibiotic therapy. In any class of emphysematous pyelonephritis, if renal preservation with medical management and percutaneous drainage proves unsuccessful, then the subsequent step is nephrectomy. But in with advanced medical management, it is now rarely required. Complicated urinary tract infection in diabetics always need imaging to document the abscess or pyelonephritis. The worsening renal function implies sepsis or obstruction. Bacteremia due to ESBL enteropathogens invariably requires carbapenems to control the sepsis or step down to sensitive antibiotics. The most cases of emphysematous pyelonephritis can be managed medically. They may need interventions such as draining of abscess and DJ stenting if there is evidence of obstruction. This is an article published in the Astrocyte journal based on the data from our own center. Again, in our center, there were 12 patients studied over two years, and the female to male ratio was 3:1. Most of them were diabetic except for one, and most of them responded to medical management alone. 2 of them had to undergo DJ stenting for obstruction, and one had to undergo a nephrectomy. Thank you, sir.